Good afternoon, everyone. I'm Dr. Vinh from Vietnam, and today I'm very happy to present my presentation titled Advance in Surgical Treatment of Congenital Airway Disease. My presentation will have four parts. The first one is what is congenital tracheal malformation or anomaly. The second is what is associated anomaly. Number three, clinical symptoms, sign, and how to diagnose the disease. Number four, how to repair, reconstruction, surgery. First, what is a congenital tracheal malformation or anomaly? By definition, it must be congenital. It means that it happened when the child was born. There are two kinds of, the main kind of tracheal malformation. The first one is the shaped tracheal tree is normal, but there are some stenosis part. The second is tracheal shape or abrasion of the tracheal is abnormal, associated with stenosis. And number four, it may be associated with some other congenital disease, mostly the lung and the heart. There is some image of the tracheal malformation. And we can see they are quite different from each to other. Yeah. But anyways, it was classified into four types. The type number one is the patient have a normal abrasion of tracheobronchial tree, but stenosis in some part of it. The type number two, the patient have additional tracheal bronchus, and this bronchus go directly to the right upper lobe. And number three, the patient have three bronchi that are arising at the same level, so we call it tripod carina. And number four, the patient have absence of the one lung, or in another words, they have only one lung. So this is type number one. The patient have a normal abrasion of tracheobronchial tree, but there are some stenosis in some part of trachea. So as you can see, the image A, B, C, D reflect the stenosis in the upper part, lower part, and in the image C, multiple stenosis. It looked like a sausage, you can see. And image D, entire trachea was stenosis. So type number two, the patient have additional tracheal bronchus, and this bronchus go directly to the right upper lobe. It also was termed by another name, like a bridge bronchus or double carina. Bridge bronchus means that this bronchus, it look like a bridge between the trachea and the upper lobe. Double carina, because the shape of the trachea now look like the patient have two carina above and below. So type number three is the patient have three distinct bronchi that arising from the carina at the same level, like a tripod carina, as you can see. And the type number one, the patient have only one lung. In another words, the patient have an absence of other lung or absence of other bronchus, and this is very severe deformity. And the part number two, I would like to say about the associated anomaly. Most anomaly associated with tracheal malformation is the pulmonary artery sling and the heart. The pulmonary artery, there are two branches, you know. So main PA bifurcate into the left and right main PA in front of trachea. But in this anomaly, the left main PA go behind the trachea, circle it, and go to the left lung. And it makes the trachea become narrowing because of pressure. And also it compromises the blood flow to the left lung. These anomalies account for around 60%, and either in the normal abrasion or bridge bronchus. For the heart, the most associated disease is ASD, VSD, and tetralogy of Fallot. We encounter all three diseases associated with tracheal malformation. And sometimes the cardiac surgeon did not notice the anomaly of the trachea before they perform the anomaly of the heart. And after surgery, post-operatively, they cannot win from the ventilator. And they try to find and detect the anomaly of the trachea. So where is the sling located? The sling of pulmonary artery either in normal abrasion or in breech bronchus. It always above the lower crina. So it's just above the crina. And it's become narrowing. So you can see in the CT image on the right hand. Yeah. And where is the ductal arteriosus located? So on the left side, you can see the image in the red color. I take it from a cardiac surgery book, but it's not correct. The ductal arteriosus never connecting the sling with the aorta. Actually, they connect the main PA to the aorta, like on the right side. We should notice about that in the repair surgery, because some pitfall here if we make some injury to this ductal arteriosus. In the first several cases, we usually transect the ductal arteriosus, but after that, 100 cases later, we ignore that. We don't transect, and the result is okay. So it's, in my opinion, it's not necessary to transect the ductal arteriosus. Number 3, talking about the clinical symptoms, signs, and diagnosis. That is a pulmonary problem. So the first symptom is the respiratory symptoms. The patient may have stridor, wheezing, asthma. Yeah, asthma is sometimes wrong diagnosis of asthma. And the patient have a repeated infection and repeated hospitalization. And sometimes they was put in ventilator and maybe prolonged ventilation. The record is usually very thick. The image study, the most important is CT scan, which is 3D reconstruction or cross-sectional. We can see very clearly the image of the anomaly or malformation. Also, we can detect the sling very clearly in this image. So in this image, you can see the tripod crina with the sling, and with left lung was completely collapsed. Bronchoscopy also very important, but sometimes the scope cannot go through the first stenocyst, so they see only small stenocyst part, but they cannot see below this. So number 4, what I would like to say about the reconstruction surgery, the indications and the technique. So indication for surgery, if the anomaly compromise the pulmonary function or respiratory symptom severe, and the patient may be put in the ventilator. This is the indication for repair surgery. The technique for reconstruction surgery or operation is sliding technique. Sliding technique regarding about the stenocyst part, we have to define the stenocyst part, and we take the midpoint of that, we translate the midpoint. But the first important, we define where is the stenocyst part as in the image. We know that Sang and Grillo is very famous about this technique. Sang is the first published about the technique, and Grillo have also several publications about the technique. And you can imagine in my drawing and also this technique, it's very easy. We transect at the midpoint of stenocyst part, and we make the lateral incision in front and behind, posterior, anterior part of trachea, and we slide together and to make the new trachea. And that is a post-operative image of a sliding technique in our series. So this is in Krainer, you can see that. And the behind, you cannot see in this one. And the above is the innominate vein. So trachea was shortened, but double in size. Sometimes the stenocyte part extends to the bronchia. And so we call it bronchial extension. In this case, we need some extension repair. But we don't follow this technique in this paper. We just do very simple one. We just make a vertical incision to the two bronchi and to make sliding to there. And that worked very well. But the most challenging type is type number 2, the breath bronchus or double criner, because this is very complicated. Some author recommend resection of the narrow part connecting two criner, but it become very challenging and almost fail in recover a normal breath for the child. So our technique here is also apply sliding, but sliding in this way, a little bit modification from the tube sliding. This is very complicated. And we make the knot in front and anterior and posterior, we like outside, vertical incision and sliding. So you can see in the red color after that. My English is not enough to explain that, but you can imagine from my drawing. For the sling, there are two techniques, transposition and reimplantation. And for me, we perform transposition where we never do reimplantation, and we consider reimplantation is not a good option for solving the sling problem. That is the transposition technique. We transect the trachea and we bring the behind sling out in front. And then we repair the trachea. So that is that the pulmonary artery, including sling, have a new position. So that's why they call it transposition. Reimplantation, on the other hand, they transect the pulmonary artery and they make a new anastomosis end to side to end with the main PA as in the image. And it's usually associated with some complication like clotting part. And this is how to explain the translocation technique. So the nature of this anomaly is a twisting between the pulmonary artery and trachea on the left side, the twist. And to solve the problem, we should bring them, separate them, and to bring the pulmonary artery anteriorly and make the trachea posteriorly. So we have two options, transect either tracheal or pulmonary artery sling. But the main point is that tracheal always transected. So it's not necessary to transect pulmonary artery. So we try to, after transect the trachea, we bring the sling anteriorly and relocate it to the normal position like the last image. After surgery, so the patient may require the physiotherapy because most of them lie in the hospital for a long time and the muscle is very weak. So physiotherapy is a help. This is some image pre-operation and post-operative. So as you can see, yeah. And this is another case. The caliper of the trachea was much improved. This is another case. And how about the sling? The CT scan shows the before and post-operation image. So as you can see, post-operation, the image of CT scan, it looked like a normal person. And the caliber of the pulmonary artery sling also improved. And of course, the tracheal also was repaired. And we also published a paper to talk about our paper. Yeah, so sorry for the image. Yeah, we have in 1927, we have almost 50 patients, but now we have maybe over 100, maybe almost 150. Yeah, so they all survived and developed very well post-operatively. So as you can see, this girl, they have a very complicated and before surgery, she was about 2 months in the hospital. But after surgery, and he also take about almost 1 month in the hospital and more. But at last, she recovered, returned to the normal life. And her mother put her in the Facebook, but it was about 7 years ago, maybe, I'm not sure. Yeah, but now she's very grow up. Thank you for your attention.